Hello, everyone. We will get started in just a minute. Give time for everyone to log on. Hello, welcome to our webinar on behalf of the American Heart Association and the National Association for Home Care and Hospice. We would like to welcome you to the AHA Heart Failure Guidelines Impact to Home and Hospice Care. My name is Courtney Hickey. I am the Quality Improvement Business Development Manager for our post-acute care certifications. I wanted to quickly go over some housekeeping rules. If you would like a copy of the handout or of the slides, that will be under your handout section of your attendee panel. There is a PDF version. Also, if you're having any technical difficulties, it is recommended that you just refresh your browser. Also, you will have the opportunity to submit online questions today. In the questions section, you can send in your questions at any time, and we will address those at the end of the presentation. If we do not get to one of your questions, we will be more than happy to reach back out to you with a response after the presentation today. Also, please keep in mind that this is going to be recorded and it will be made available after the webinar via email to all registrants. It is now my pleasure to introduce our speaker for today, Dr. Larry Allen. Dr. Larry Allen is the Interim Division Head for Cardiology, Medical Director for Advanced Heart Failure, and Co-Director of the Colorado Program for Patient-Centered Decisions at the University of Colorado. Dr. Allen's interests include anticipating progression into end-stage heart failure, and then helping patients make tough choices regarding invasive therapies and palliative options. Dr. Allen led the PCORI-funded DECIDE-LVAD trial on patient decision support and the AHA-funded EPIC-HF trial on patient engagement and medication prescribing. Meanwhile, Dr. Allen keeps himself clinically grounded by regularly seeing patients with heart failure, LVADs, and transplants, and is consistently voted as one of Denver's top doctors in the 5280 magazine. It is now my pleasure to turn today's presentation over to Dr. Allen.
Well, thank you. It's a real pleasure to speak on behalf of the American Heart Association. For those of you who don't know, the AHA is really the premier organization in the United States that represents patients. There are other professional organizations that are out there, but the AHA is the patient voice and really does an incredible amount of work to improve the care of cardiovascular disease in general, but specifically for those patients with heart failure. My disclosures are probably most important to let you know that what I spend my days doing and what I don't do. I am principally an advanced heart failure doctor, and I do see patients on the inpatient and outpatient side. I have spent a lot of time over the last 5 years doing clinical operations with the hospital, and that has included a lot of work in transitions of care and working with our community partners. And then I do a fair amount of research focused on risk prediction as well as how to engage patients and improve medical decision making. And a lot of that involves how to get patients home, remain independent, choose between complex therapies. So I'd love to talk about all of that today. What I don't do is I'm not a case manager, and I don't spend a lot of time actually delivering care in the community. So I hope at the end we can have a good discussion about people's perspectives on the other side of this, outside the hospital walls. I'm also here today because I was one of the writing members of the newly released American Heart Association heart failure guidelines for the evaluation and management of heart failure. The guidelines, I think, are a really exciting document for a number of reasons. One is that the heart failure guidelines are the most read guidelines and downloaded guidelines of any of the cardiology guidelines in the United States. And it's not surprising because so many of us deal with heart failure on a regular basis. The new guidelines are a full update, and they were released on April 1st of this year. And they were the first full update since the last guidelines in 2013. So they are markedly revamped after nearly a decade. And they're very exciting because I think in the 2000s, there weren't a lot of new therapies in heart failure. And what we've seen over the last few years is a huge interest and development in the field of heart failure for a number of reasons. One is there was the public policy measures around readmissions, and so a ton of energy around transitions of care. And in the meantime, we've seen new drugs like sacubitril valsartan and the SGLT2 inhibitors, as well as new devices, including invasive remote monitoring devices around pressure, and just a number of studies in the field that I think have really transformed the care of patients with heart failure from 2013 to 2022. Now, the guidelines are easy to download. They're available on the internet. If you type in AHA heart failure guidelines, you can easily find them. They include a lot. They're 101 pages and include a wide variety of sections on the full gamut of heart failure. But I think interestingly, they include a number of sections that specifically address what happens to patients after they leave the hospital. So section 7 talks a lot about managing patients with symptomatic heart failure, and it includes a lot of mentions of self-care, which patients obviously do by themselves at home, as well as home care and home aids. Section 9 talks a lot about transitions of care for patients hospitalized who are leaving the hospital. And then section 13 is actually dedicated to end-stage heart failure and the transition to palliative care and other complex medical decision-making. So those are some highlights that you may want to peruse on your own, either during or after this talk. So I'm gonna take us to the first slide. And we'll start out with the epidemiology of heart failure. I think part of the reason we're here today is it's hard to go far in medicine without crossing heart failure. And unfortunately, despite the advances that I talked about, heart failure is not going away. So there's been an increase in heart failure related deaths in the most recent data. And the very recent data shows that this has increased, particularly in the last few years, in part because of the pandemic. There have been generally an increase in the total number of heart failure hospitalizations, so we haven't cured that problem. And there has been a decline in the overall incidence of new heart failure, but that incidence has been complicated in recent years, where it's unclear if that will continue. And there has been a shift from patients with heart failure and reduced ejection fraction to patients with heart failure with preserved ejection fraction, which tends to occur in patients who are a little older, have multimorbid disease and frailty, who are more likely to need home care. The other critical aspect of heart failure is that there are significant racial and ethnic disparities in heart failure itself and in death. And the age-adjusted mortality rates for patients who are Black are significantly higher than for others. So this obviously requires additional attention and consideration. Next slide. Some heart failure statistics. The prevalence is expected to increase in the next few years, as I mentioned. I think importantly, this incidence is not just in HFpEF and older patients, but also in younger patients. Unfortunately, I'm seeing some of this due to poor self-care and abuse of alcohol and methamphetamines. Heart failure is significant. There are 6.5 million Americans who are estimated to have heart failure in 2019. And heart failure is a common cause of death at the end of life. And the CDC says that it was a contributing cause in at least 1 in 8 deaths. Next slide. Related to home care, which I think all of you are most interested in, there are more than 600 million patient visits each year to home care. Approximately 70% of those people using home health care services are over the age of 65, and the most common condition among those older patients is heart disease. The #1 discharge destination for patients with heart failure who have been hospitalized is to home, with about 73% of heart failure discharges going to home. I will add that many of the additional people who don't go directly home go to acute rehab and then eventually go on to home again. So this is the vast majority of where patients go to in their transitions out of the hospital. And 34% of those heart failure patients require home health services, and this has been increasing year by year for obvious reasons. Next. Just to touch on hospice and palliative care, some of this is very well known to people on the call, but we know that hospice care is a form of care that is covered by health insurance. It is an approach to care that is essentially reserved to patients who are felt to have a life expectancy of less than 6 months. There's a qualifying for hospice requires a physician order and generally 2 providers to feel that the patient qualifies. And most hospice patients begin their care in just the last few weeks of life. And one of the challenges we've had in heart failure is that it's a somewhat unpredictable, undulating disease, such that we'd like to be able to anticipate end of life, but that's hard. And so many patients are referred to hospice in what I would consider it being too late, where they enroll in hospice. A lot of effort has gone into setting up hospice, and patients spend hours to days with hospice without really probably benefiting from the effort required to set up hospice. Unfortunately, there's also the other end of the spectrum where we have patients who have an acute decompensation of heart failure. We don't think we're able to get them better. We enroll them in hospice, and then for whatever reason, they tend to improve. And then patients are alive after 6 months. And that's okay, although some patients and families are confused about the messaging that's been given. And then if those rates are too high, the insurance companies question about whether the referral was appropriate in the first place. On the right here, I think some other stats to give context to this. There are about 2.9 million deaths per year in the United States. There's been some great data published showing that hospice care has increased pretty significantly in recent years. And now about 1.55 million people receive hospice care. And 1 in 3 patients with heart failure will use palliative care or hospice care, which is a marked and progressive increase in hospice care for patients dying of heart failure. And then finally, heart failure patients discharged to hospice care, again, as I mentioned, have a median survival of only 11 days, with 1/4 of those patients dying within 3 days. Next. So I'm going to jump into some data from the guidelines themselves so that you can see portions of the guidelines and how that may help you in your approach to home care and palliative care. So the guidelines actually start off with defining heart failure, and I think that's important because heart failure is a syndrome where often I tell patients it's a garbage term. It just means your heart's not working as well as we would like. But it's important to group patients into that because so many of the things that we do in terms of therapy really apply broadly across the diffuse and heterogeneous syndrome of heart failure. So one of the key things to think about in terms of heart failure is this concept of staging, which has been used in COPD and cancer and other diseases, but it applies very nicely to heart failure. So we've got 4 stages, and we start out with stage A, which is patients who do not have heart failure but are at risk for heart failure. And these patients, the reason to emphasize stage A is that these are the patients where we can prevent heart failure by addressing the causes. And so stage A, I think we shouldn't ignore, because if we really want to make a difference in heart failure, we should prevent it from happening in the first place. Next. Stage B heart failure is patients who have pre-heart failure. These are patients who don't really often know they have heart failure. They don't have noticeable symptoms of heart failure. But if we go looking, we can see that they already have changes to the heart that are consistent with the changes we see in patients who have more symptomatic or severe heart failure. And so this includes structural changes of the heart itself that you can often see on echocardiogram, evidence of increased filling pressures or early congestion if we were to measure those either invasively or by ultrasound, and then patients who have other signs of this, which would include elevation of natriuretic peptides or even markers of chronic injury to the heart through cardiac serum troponins. Next slide. Once patients have symptoms of heart failure, often starting with a hospitalization for heart failure, those patients are stage C, meaning that they've got structural changes to the heart, they've had symptoms, they're having consequences that are affecting their life, and generally these patients now have to live with heart failure for the rest of their life. And then once patients have progressive heart failure that has severe symptoms that can't be reversed, we call that end-stage heart failure, stage D heart failure. Most of the patients, or about 80% of the energy that we spend in heart failure, is actually on those symptomatic but stable stage C patients. Next slide. And this is just a figure from the guidelines highlighting those different stages. Next slide. This transition from stage C heart failure, patients who have symptoms, maybe even in and out of the hospital, they are using diuretics potentially to control volume. They have shortness of breath, swelling, fatigue. Those patients, when those symptoms get worse and cannot be improved despite best medical therapy, we think of those patients transitioning from stage C to stage D, or advanced heart failure. This is an important transition because these patients are very high risk for having suffering and low quality of life, for having recurrent hospitalizations, and for having a death that's not well planned for. So a lot of the effort that I've spent in my career is helping people think about identifying this transition from stage C to stage D in an orderly fashion, so that we can prepare patients appropriately and put into place either palliative care or advanced heart failure therapies like transplant and LVAD in a timely fashion, rather than waiting until patients are really in extremis at end stage and either going to hospice for 2 days or coming for a transplant evaluation when they have end organ dysfunction. There have been a lot of risk models developed to predict patients who are end stage, but I have to say this mnemonic came out from a colleague and was published about 5 years ago, and I use this mnemonic all the time, and it says, I need help. This is your patient who has any of these things is saying to you that I need help. I'm not doing well on standard therapy, I'm not responding to medications, and I need you to do something more for me and change the approach to care. So the I stands for intravenous inotropes. So if patients are getting hospitalized and need dobutamine, and certainly if they're sent home on dobutamine or milrinone, that's a patient who is end stage and dying, and we shouldn't ignore that. We should have a plan in addition to the inotropes. Next is N for New York Heart Association class, patients who have really severe symptoms all the time. And it also stands for, there's a second N for elevated natriuretic peptides. So the BNP is high and you can't get it to come down with diuresis. E stands for end organ dysfunction. I've been called a glorified nephrologist because so much of what we do is follow kidney function in heart failure. And if the patient has a really good creatinine and is responding well to diuretics, oftentimes that's a very good prognostic sign. And conversely, patients who need higher doses of diuretics, who are having rising creatinine and acute renal dysfunction, can't be diuresed, those are patients who are in trouble. Similarly, patients who have shock liver or liver congestion evidenced by high bilirubin, those are patients where not only is the heart falling apart, but the rest of their organs are falling apart, and that is a bad sign. Ejection fraction is interesting. People very much emphasize ejection fraction. It is important, but I almost de-emphasize it here because left ventricular ejection fraction is only a modest predictor of prognosis and a modest predictor of symptoms. So certainly if patients have an ejection fraction of 15%, they get put on therapy, including our, beta blockers, sacubitril, valsartan, spironolactone, SGLT2 inhibitors, and their ejection fraction doesn't respond. That is a concern, and so we don't want to ignore that. But again, I don't want people to overemphasize that just because a patient has a normal ejection fraction that somehow they're okay. Ventricular tachycardias and shocks from defibrillator are a sign of severe disease. They're also a sign of suffering because we don't want patients to suffer a number of shocks at the end of life. One of my favorite predictors of patients who are not doing well is if they continue to come into the hospital. We spent a lot of time at our hospital developing a complex risk score that we could calculate in real time to predict who is going to come back to the hospital. And what we found is that about 90% of the information of that risk model could just be captured by who'd been in the hospital more than once. If patients get hospitalized and they come back, they're not doing well in the community and something different needs to happen. I already talked about edema and escalating diuretics. Hypotension is not your friend. A frequent comment I make to my house staff that I'm training is if you have a patient who has a blood pressure of 90, another patient who has a blood pressure of 120, and a patient who has a systolic blood pressure of 150, which of those patients would you like to see come into your clinic? And even though we want to lower patients' blood pressure when they have heart failure, if their blood pressure is spontaneously low, that is a bad prognostic sign, and it also limits our ability to treat them. So I like to see patients actually have a generous blood pressure that I can work with, and that's a good prognostic sign. Similarly, tachycardia is a sign that patients are not doing well, and patients in whom you can't really get that heart rate down, it's a concern. Also, patients who have atrial fibrillation have higher risk, and atrial fibrillation with rapid ventricular responses complicates management and is also another sign of bad prognosis. And then finally, patients do better if they have a low ejection fraction and they get on guideline-directed medical therapies, as I mentioned. If they don't tolerate those therapies, or if they were doing well on those therapies and those therapies need to be removed, those are patients who are in trouble. I spent a lot of time on this slide, but this is a really key slide because if you are at home with patients, helping them either through home health or through palliative care or hospice care, these are the things that let you know the patient is getting towards end of life. And either we need to prepare for that, or if we weren't prepared for it, we need to regroup and reconsider what our approach to care is. Next slide. I got into this a little bit, but again, trajectory is important. Patients with heart failure are not often cured. So most patients that you'll see, they have an initial diagnosis of heart failure. Oftentimes after their initial presentation, they can be improved through diuresis and treating any other exacerbants and putting them on heart failure therapies. And a lot of times they will have a period of relative stability. But then many times the underlying disease, whether that's genetic or cardiac or ischemic, will progressively get worse, and we'll see patients start to slip into persistent heart failure and then worsening heart failure. And that's a sign that we're moving again into from class C or stage C into stage D advanced heart failure. Next. Ejection fraction remains very important. So beta blockers and mineralocorticoid receptor antagonists like spironolactone and eplerenone, and for the most part, the renin-angiotensin-aldosterone inhibitors like ACE inhibitors, angiotensin receptor blockers, and sacubitril/valsartan, those drugs seem to work much better for patients who have an ejection fraction of less than 40%. And so we continue to use this framework because it helps define which medical therapies are likely to work for the patient based on their ejection fraction. Similarly, some of the devices like defibrillators and CRT are more indicated in patients with low ejection fraction. However, I will make the caveat that this a division of patients into HFrEF or NEF of less than or equal to 40%, this mid-range or mildly reduced EF in the 40s, and then HFpEF or preserved above 50, it has fallen apart a little bit with the advent of the SGLT2 inhibitors, which seem to provide benefit across all ejection fraction for patients with heart failure. The other is that sacubitril/valsartan is a drug that does seem to have quite a bit of benefit in the heart failure with mid-range ejection fraction, and the FDA has approved it for all patients with heart failure with a note that it likely has greater benefit for patients with lower ejection fraction. Next slide. And then this gets into the fact that ejection fraction is dynamic. There are patients who start out with, say, amyloid cardiomyopathy with a normal EF and restrictive physiology and can be quite sick, but may progress to a low EF. There may be patients who start out with ischemic heart disease similarly who have a normal ejection fraction, but some diastolic dysfunction, but may progress. And then vice versa, there's a group of patients who start out with low ejection fraction. I often think of patients with dilated cardiomyopathy with, say, a Titin mutation, in whom, when they're started on guideline-directed medical therapies, often will have significant improvement, not only in their symptoms and heart failure, but they can have normalization of their ejection fraction. These patients we're calling heart failure with recovered ejection fraction who are in remission. And I think one of the key takeaways is that ejection fraction can change, but patients who've had symptomatic heart failure rarely are cured and need to continue to often take therapies for heart failure, as well as avoid any precipitants or exacerbants of heart failure because they remain at high risk for developing recurrent symptomatic heart failure. Next slide. The causes of heart failure are diffuse. About 40%, it depends, of heart failure is related to coronary artery disease with ischemic heart disease. But there are many causes of heart failure that are not due to myocardial infarction or coronary disease. Perhaps some of the most common are longstanding hypertension, but there are also genetic causes, including Titin mutations, as I mentioned. There are an explosion of chemotherapies, and many of the new chemotherapy agents have cardiac effects and can cause heart failure, including adriamycin or doxorubicin is the classic one, but Herceptin is another drug that can do this. There are autoimmune diseases. There are tachy-mediated or AFib with uncontrolled rate can do this. And then increasingly, as I mentioned, we're seeing substance abuse, particularly methamphetamines, as a cause. And then during the COVID pandemic, we saw some patients with COVID-related myocarditis, as well as vaccine-related myocarditis. Next slide. I also, we thought it would be good to go through the top 10 things to know about the new updates. There was a lot of time spent on trying to distill these 101 pages into a few take-home notes. So I'll just read through these. Next slide. Number 1 is guideline-directed medical therapy for heart failure with patients with reduced ejection fraction, which is defined as an left ventricular ejection fraction of less than or equal to 40%, now includes 4 medication classes, which we are sometimes calling quadruple therapy or the 4 pillars. And these 4 medication classes have all been shown to improve all-cause mortality in randomized controlled trials. And those 4 classes I often talk about being evidence-based beta blockers, sacubitril valsartan, the neprilysin inhibitor combined with an angiotensin receptor blocker, the mineralocorticoid receptor antagonists, spironolactone and eplerenone, and the new 4th category being the sodium glucose transporter inhibitors. Next. Number 2, SGLT2 inhibitors have a 2A recommendation in heart failure with mildly reduced ejection fraction, and but I think actually with additional data coming out about dapagliflozin in patients with heart failure and preserved ejection fraction that whose top line results have been released but will be discussed at the end of the month at the ESC, I think you're going to see that SGLT2 inhibitors now have a strong recommendation across all heart failure regardless of ejection fraction. And then there are weaker recommendations made for sacubitril valsartan and mineralocorticoid receptor antagonists and beta blockers in patients with ejection fraction in the 40s. Next. Number 3 is new recommendations for heart failure with preserved ejection fraction, again, are made for SGLT2 inhibitors, as well as MRAs and sacubitril valsartan. Many prior recommendations have been renewed, including treatment of hypertension, treatment of atrial fibrillation, use of ARBs, and avoidance of drugs that have been shown to worsen symptoms. And those include nitrate drugs and phosphodiesterase inhibitors like sildenafil, which in trials actually were not only neutral, but looked like they made people feel worse. Next. Number 4, improved left ventricular ejection fraction is used to refer to those patients with previously low EF who have now improved on therapy. And again, this is this heart failure in remission where these patients, unless there was some acute insult to the heart that has clearly been resolved and there's no permanent damage to the heart, these patients still have underlying heart failure and they should continue their heart failure treatment. And neither their clinicians nor the patients themselves should generally stop their heart failure therapies or their guideline-directed medical therapy. Next. Number 5, value statements were created for select recommendations where high-quality, cost-effectiveness studies of the intervention have been published. So one of the things I think that is fabulous about the new guidelines is they actually talk not only about the evidence about the risks, benefits, and concerns about the drugs, but also look at the cost of these various drugs and make recommendations about their use, about being high value, moderate value, low value, or questionable value. And this is really new to the guidelines. Next. Number 6 is amyloid heart disease is gaining increased attention because there are better diagnostic modalities for it, as well as new treatments. So amyloid heart disease has new recommendations for treatment, including screening for serum and urine monoclonal light chains, bone scintigraphy, genetic sequencing, and then therapy with tetramer stabilizing therapy, the drug being tafamidis, as well as anticoagulation. So if you have patients who have a diagnosis of amyloid, whether that's amyloid light chain disease or amyloid TTR for transthyretin disease, these patients now have an increasing number of targeted therapies for their disease. Next slide. 7, evidence supporting increased left ventricular filling pressures is important for the diagnosis of heart failure with a preserved or normal ejection fraction. Evidence for increased filling pressures can be obtained using natriuretic peptide data from lab tests or from echocardiography data, or if there's a real question, invasive testing with right heart catheterization and hemodynamic measurements, including with exercise, can be used to confirm these diagnoses of HFpEF, which can be difficult in patients with edema and multimorbidity. Next slide. Number 8, patients with advanced heart failure who wish to prolong survival should be referred to a team specializing in heart failure. And this would be an advanced heart failure and transplant cardiologist like myself and the team that I work within. A heart failure specialty team reviews heart failure management, assesses suitability for advanced heart failure therapies like transplant and LVAD, and uses palliative care, including palliative inotropes, where consistent with patients' goals of care. And so there's a specific call out in the take home about the collaborative nature between palliative care teams, hospice, and advanced heart failure practitioners like myself. Next. Number 9 is primary prevention is important for those at risk of heart failure, stage A, and pre-heart failure, stage B. Stages of heart failure were revised to emphasize this new the terminology of at risk and prevention so that people don't ignore pre-heart failure. Next. And finally, recommendations are provided for select patients with heart failure and iron deficiency, anemia, hypertension, sleep disorders, diabetes, atrial fibrillation, coronary artery disease, and malignancy, because so many patients with heart failure actually have multiple chronic conditions, and the care of these patients cannot only focus on their heart failure. One of the things I often tell people is, you're not going to make progress in managing somebody's heart failure if you're not willing to really coordinate care and collaborate with other practitioners. Next slide. So for patients who are hospitalized with heart failure, who are mostly going to go home, so there are a lot of recommendations for what to do in the hospital. And these include, in the evaluation process, addressing precipitating factors, many of which started at home. And if we don't do a good job understanding those precipitants, those things will recur when patients go home. Evaluating the severity of congestion and treating with diuretics, and then assessing the adequacy of perfusion and whether patients are really in shock. The goals of guideline-directed medical therapy are really to optimize volume status. One of the key things we do is adjust diuretics, both in the hospital, but then in chronic care in the ambulatory setting. Address reversible factors. Let's fix what we can fix. And then continue and or intensify guideline-directed medical therapies that can stabilize the disease. Again, we should really think about what are the precipitating factors for patients who have been hospitalized so that we can either treat those or make sure they don't happen again when the patients go home. And these include worsening coronary disease, uncontrolled hypertension, new atrial fibrillation or uncontrolled atrial fibrillation, acute infections, non-adherence to medications, which can be complicated. Most patients often do a good job with their medicines, but maybe don't do a perfect job. Anemia and iron deficiency, thyroid disease. A common problem we see is patients who are started on amiodarone and then develop usually hypothyroidism, but occasionally hyperthyroidism. Medications that worsen sodium retention, like the use of NSAIDs or ibuprofen for arthritis, And then medications with negative inotropy, such as non-dihydropyridine calcium channel blockers like verapamil, but there are many out there. Next slide. So let's talk about once the patients leave the hospital, or patients who are in the ambulatory setting who have significant either heart failure that needs extra help, or they have other medical problems that exist, and they also have heart failure. Next slide. So patients leaving the hospital, again, the last decade have seen a ton of attention focused on transitions of care, again, because of many of the policies, including the hospital readmissions reduction program. But a good transitional care plan before the patient leaves the hospital should include a scheduled follow-up with somebody who can manage heart failure in the next 7 days. This can be a heart failure person, or it can be primary care. Referrals to multidisciplinary heart failure management programs have been shown to improve overall care. Now, not all patients in the United States can be managed by a heart failure specialty clinic, but I do think patients at high risk who have complex disease or who have a low ejection fraction tend to benefit more from this. Participation in benchmarking programs have been really helpful. I spend a lot of time working with the AHA's Get With the Guidelines program about hospital care, but there are a number of quality improvement programs out there that we're going to talk about at the end that can really, I think, share best practices, help us organize our care, and then give us feedback about how we're doing and benchmark that against our peers so we know what we're doing well and really where we could do better. That's in the guidelines. Addressing precipitating causes of high risk and high risk factors. Again, I already mentioned that, but there's a special call out in the guidelines to comorbidities, which are a huge issue, as I mentioned, as well as social determinants of health, which have a lot of impact on precipitants as well as adherence. Anybody who takes care of heart failure patients really has to become comfortable with volume status assessment and adjusting diuretics and being comfortable with that with various diuretics. And then finally, a coordination of a follow-up, including vital signs, but oftentimes we're getting basic metabolic panels to see where patients' potassium and creatinine are. Next slide. Recommendations around disparities in vulnerable populations are specifically addressed in the guidelines. This is a priority of the American Heart Association, I think is critical just to our culture. But one, in vulnerable patient populations at risk for health disparities, heart failure risk assessments and multidisciplinary management strategies should target both known risks for cardiovascular disease and specifically social determinants of health as means toward elimination of disparities in heart failure care and outcomes. And another recommendation is evidence of health disparities should be monitored and addressed at the clinical practice and healthcare system levels. And obviously this carries out from the hospital into the community and the home. Next slide. And then performance measures. In the guidelines, it says performance measures based on professionally developed clinical practice guidelines should be used with the goal of improving quality of care for patients with heart failure. And again, participation in quality improvement programs, as I mentioned, including patient registries that provide benchmark feedback on nationally endorsed clinical practice guideline-based quality and performance measures can be beneficial in improving the quality of care for patients with heart failure. Next slide. Again, I mentioned that one of the last sections of the guidelines, section 13, talks a lot about end of life and then focusing on goals of care. But there are class 1 recommendations that for all patients with heart failure, palliative and supportive care, including high quality communication, conveyance of prognosis, clarifying goals of care, shared decision-making, symptom management, and caregiver support should be provided to improve quality of life and relieve suffering. Now, this need is greater as patients move into stage D, but this should really be provided across the spectrum of heart failure, including patients with stable symptomatic disease. Another class 1 recommendation is given for patients with heart failure being considered for or treated with life-extending therapies. The option for discontinuation should be anticipated and discussed through the continuum of care, including at the time of initiation and readdressed with changing medical conditions and shifting goals of care. This is particularly important for patients with implantable cardioverter defibrillators, that they need to know what the purpose of a defibrillator is, and that it can be turned off when the goals of care shift and patients are worsening. Some additional recommendations for patients with heart failure: execution of advanced care directives can be useful to improve documentation of treatment preferences, deliver patient-centered care, and dying in the preferred place. And these advanced care directives require updating and ongoing discussion. For patients with heart failure, particularly stage D patients being evaluated for advanced therapies, patients requiring inotropic support like dobutamine or milrinone, or temporary mechanical support, patients experience uncontrolled symptoms where there's significant suffering, or for patients who have major medical decisions that are complicated, or for patients who have heart failure that's complicated by multimorbidity, frailty, or cognitive impairment, dementia, specialist palliative care consultation can be particularly useful for them. And in patients with advanced heart failure and expected survival of less than 6 months, timely referral to hospice can be useful to improve quality of life. These are specific recommendations in the guideline in section 13 that speak to how to handle end of life, and specifically hospice. Next. So there is a little bit of discussion about patient-reported outcomes. Patients don't just care about survival, they also want to feel good. And this requires us to actually assess how they feel. Now, we've traditionally relied on the clinician assessment of New York Heart Association functional class, and that's still useful, but there are questionnaires like the Kansas City Cardiomyopathy Questionnaire or the EQ5D that can also give patient-reported measures and some collection of, systematic collection of how people are feeling is important. Next. So last slide, just a few top takeaways from the talk for the heart failure population with home care or hospice needs. Number one, the 2022 American College of Cardiology, American Heart Association, Heart Failure Society of America guidelines offer an updated summary of best practices for evaluation and management of heart failure, including specific recommendations around the integration of home care and hospice. Number two, home care and hospice are important considerations for patients recently hospitalized and transitioning back to the community. And three, home care and hospice are important considerations for patients progressing into advanced heart failure who are refractory to medications and devices. Thank you. I'll turn it over now.
Thank you so much, Dr. Allen. Again, please submit your questions in the question section, and we are going to get to those in just a second. While we're waiting for those questions to come in, I wanted to introduce Amy Guberman from the National Association for Home Care and Hospice and Steve Dental from the American Heart Association to briefly share some information.
Hi, everyone. Good afternoon. Thank you, Courtney, and I'd like to thank Dr. Allen for including end-of-life considerations into this clinical guideline. I'm Amy Guberman. I am the Director of Education for NAC, the National Association for Home Care and Hospice. NAC is honored to be a part of this webinar in conjunction with the American Heart Association. The National Association for Home Care and Hospice is a nonprofit association that represents home care and hospice organizations that support the provision of healthcare in the home. NAC provides the highest quality of education and advocacy to more than 2 million staff employed by such organizations that offer in-home services to over 12 million Americans who are infirmed, chronically ill, experiencing a disability, or dying. Along with education and advocacy, we help members extend the highest quality of care in the home, and we are committed to excellence in every respect. To learn more about the National Association for Home Care and Hospice, or to become a member, please visit nahc.org. That's NAHC.org. Steve?
Thank you both, Dr. Allen, and special thanks to NAC for being a collaborator on this webinar. Just wanted to share a little bit of information. You know, as Dr. Allen shared, you know, the prevalence of heart failure is projected to skyrocket, and the post-acute care of heart failure patients is so important. As a result, in the past couple of years, we have launched several certification programs for your agencies to actually become part of. And it's a great opportunity because one of the requirements for the certification is that your heart failure program at your agency is utilizing evidence-based guidelines. So, and also is collecting data, you know, as we've seen is an important aspect within the guidelines itself. So for those of you on the call, you know, again, we've launched several certifications, including home health and palliative hospice certification for those agencies out there. Next slide. And if you need more information, or if you're interested about our certifications, please don't hesitate to email us and we can follow up with you at certification@heart.org. At this time, I am going to go to some of the questions that we have had come in. One of the questions, Dr. Allen, this is, I think you talked about this, but as a nonprofit hospice, we have to watch our costs and struggle to justify the use of Entresto or the SGLT2 inhibitors. What would be your recommendations considering cost and use of these medications?
So that's a great question. And you know, the way that I see this play out is we'll have patients who get hospitalized for worsening heart failure in the hospital. We're really struggling to get them improved. We have discussions that they're moving into stage D and end of life. Our case management kind of engages them with a hospice agency or multiple so they can choose. And sometimes our palliative care specialty team helps kind of either coordinate or facilitate discussions around this. And what I often get asked is, well, you know, we're changing kind of our goals of care from life prolonging to really quality of life for these patients. And patients will say, well, I want to continue the things that make me feel good. And they'll say, well, I think these expensive therapies do that. And that could be sacubitril valsartan, as some people do feel better with afterload reduction. And then sometimes it will also relate to drugs that are fairly expensive, like home infusion of dobutamine milrinone, which some hospice agencies will take on, but others will not due to the cost issues that you bring up. So I guess my first piece of advice is that all the people involved that I just mentioned, including not just the hospice agency, but the clinicians like myself, the case managers, the other team members, they need to understand what the limitations are in terms of what the hospice can and can't provide, so that we're messaging from the start about what is reasonable to continue versus what is not. And then I think we need to, have a healthy discussion about what it truly means to transition to hospice, and that, you know, coming off drugs like anticoagulation, turning off the defibrillator, not being on expensive therapies that are really primarily designed to improve length of life, that we go into those discussions really having a good understanding of it, and then the language that doesn't confuse people. Specific to sacubitril valsartan, I will say that the data is that it does improve quality of life, but not that much. So if you look at the Paradigm trial, and these are not in-stage heart failure patients, but the KCCQ is improved less than 2 points. So I think you can make an evidence-based argument that switching from sacubitril valsartan or Entresto over to enalapril or some other generic ACE-ARB probably does not worsen quality of life significantly. So to me, there's some evidence behind that. And then for the SGLT2 inhibitors, they're pretty well tolerated. They do improve quality of life. The KCCQ improvements are around 5, but primarily they're really being used as a disease-modifying drug to try and improve overall heart function. And I think when patients go to hospice, that we've really changed our focus away from that. So that's a very long answer to say that I hear what you're saying. The finances for hospice as currently constructed don't really support the continuation of those drugs. The conversations are complicated, but overall, I think if done expertly, I think it's reasonable to stop those drugs and not lead to a lot of confusion.
Another question, Dr. Allen. There is the guideline for determining terminal prognosis, heart disease initial certification. Do you feel that there are additional factors that should be considered when reviewing eligibility for hospice care for the heart failure patient population?
So it's interesting. I feel both comfortable and uncomfortable answering that question because I've spent a lot of time taking care of patients with advanced heart failure. I've done a lot of research in prognosis, but I'm also not a hospice physician, so I don't see that side of it. What I will say is that I often feel uncomfortable saying a patient has less than 6 months to live because I do think heart failure is a somewhat unpredictable disease, and I occasionally get that wrong. But that's the nature of medicine, and I often will tell people that, we used to compare heart failure to cancer, where cancer was pretty predictable once you had metastatic disease and heart failure was unpredictable. But as we all know, with some of the development of the new cancer therapies, cancer's become unpredictable too, right? We're seeing patients who have metastatic severe disease, they get put on some targeted agent, they have a great response, and they're alive 2 years later. And so I think we're all dealing with this issue of prognosis being a challenge. And so I think we need to make our best guess. The second is there is a lot of data to at least push people, into, I think they're going to do well for months to years versus I think this patient really has weeks to maybe months to live. And I gave you the I need help mnemonic related to heart failure itself. But I think other things to think about beyond heart failure are the concept of frailty, which I think is pretty critical. There's a huge literature on frailty for older patients and how that affects prognosis. And then I do think that a lot of these patients have multimorbidity. And so thinking about the fact that a patient with bad heart failure is one thing, but a patient who has bad heart failure, severe COPD, as well as either cancer or dementia and older age with frailty, those are things that compound the prognosis of a patient who already has bad heart failure. So not really an answer for you, other than to say it's not an exact science. We do our best, and then we reevaluate over time. And it's okay if patients graduate from hospice, is my opinion, as long as it doesn't happen too often.
We'll ask one last question. This will be quick, and then we'll wrap up. Can a home health nurse determine a patient's New York Heart Association stage, or does that need to come from a physician provider or a clinician provider?
I think it depends on what the NYHA functional class is being used for. Like for our research studies and some of the other regulatory things we have, it is what is a physician or clinician's healthcare provider's assessment of that. But the New York Heart Association functional class is not rocket science, right? NYHA class 1 is patient doesn't really feel like they have heart failure. And NYHA class 4 is the patient is extremely limited. They feel bad either all the time or they feel bad with trying to do anything. And then there's really NYHA class 2 and 3 in between, which is class 2 is they have very mild symptoms, usually just with a significant exercise. And class 3 is that they have a lot of symptoms, but not so many that they're in, they're really incapacitated. So again, NYHA class is, I just think, kind of this thumbnail of, roughly where is my patient today and how they're doing. And I think it's, in my mind, it's okay for home health folks to use that language if it's helpful for them and helpful for the people that they're working with.
Thank you, Dr. Allen. Courtney, do you want to wrap things up?
Yes, so I would like to thank you, Dr. Allen, for leading today's webinar, and thank you everyone for your participation in today's event. After today's webinar, you will receive a follow-up email with a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. And that you a recording of today's presentation. If you are looking for additional information on the National Association for Home Care and Hospice or the AHA certification programs, please refer to the 2 slides for the website addresses. And this information will also be included in the follow-up email. On behalf of the American Heart Association, National Association for Home Care and Hospice, and Dr. Allen, thank you for joining us and have a good day. This concludes today's presentation.
Thank you, everybody.